Good morning, everybody. Thank you for joining me today. I'm sorry for the delay. We had a little technical problem with the video camera, so you'll just have to hear me and not see me, which is probably okay for me too. But my name is Rachel Gardner, and I'm a psychologist and the director of the Fraser Autism Center of Excellence. We are located in Minneapolis, and we are a nonprofit organization, the largest and oldest of autism services in Minnesota. We have 6 different clinical sites across the metro area and offer a vast array of services to thousands of kids and their families every year. I've had the privilege of working for Fraser for over 20 years. I really want to make this workshop the most helpful to you, so feel free to go ahead and send me questions if you like throughout the workshop. I will be stopping halfway just to make sure there are no questions, or that'll be a time that you could ask anything that might be of interest to you, and I will also leave some time at the end as well. The intent of this workshop is really to help families who have recently gone through the diagnostic process. We know what an exhausting process that can be. It's an important step in the process for sure, but we also know that after you hear the initial information, it can sometimes be hard to remember everything that was said during that feedback session. And so this workshop is really intended to do a couple of different things: to review the definition of an autism spectrum disorder, as well as how do you start the next steps in developing intervention for your child. When I have done this workshop in the past in person with others, I have found that we often have a wide range of ages represented. So I will do my best to try to address all of the different ages, but if you have specific questions, again, for very young kids or older kids, please feel free to type me a question as well. So we're going to talk about today, where do you start after you have a diagnosis? It can be quite challenging to weed through all the different options out there. The good news is, in the past 20 years that I've been doing this work, there has been a huge growth of services and options available to family. That wasn't the case back in the day, and parents are becoming much better consumers and need to have the information to make good choices about what's going to work for their child and their family. So we're going to talk about that fine balance of how do you figure out what's going to work for your child and your family by balancing the concerns as long as with the needs of everybody in your family, not just a child who might be diagnosed with an ASD diagnosis, but parents, grandparents, siblings, and what options might be out there, and how do you know which one might be a fit for you. I'm going to tell you up front, it's not easy, and it might change, so your needs and your concerns are going to change over time, and therefore what you choose as intervention might change as well. So I'm just going to talk briefly a little bit about what is autism. Again, I'm assuming that if you've recently gone through the evaluation process, you had a feedback session with a mental health professional who has described this for you. But again, in my experience working with a lot of families over the years, I know that after I've given a feedback to families, oftentimes there's just so much information there that they sometimes struggle to remember all the details that were shared. So we'll go through a little bit about that today. Things have changed in the autism world with our new diagnostic manual as well, so I'll talk about that a little bit, and then we'll dive into services. So when we're talking about autism spectrum diagnosis, what we're really looking at are qualitative differences in 2 specific areas. I really want to point out that it's not that kids do not have skills in these areas, but it's really more about the quality of how they use their skills in these particular 2 domains that help us look to see if ASD is appropriate or not. We're really looking at how they use their skills in their social communication and interaction with others. I think in my experience has been a big misnomer that kids on the spectrum do not want to interact with other kids or have friendships. I actually find that a lot of our kids really do have that motivation and desire, but just don't know how to initiate interactions with others, how to keep those friendships, how to navigate the social world, which can be very complex. For younger kids, we're looking to see how well they can establish joint attention with other people. How well do they respond when somebody says, "Hey, look, there's an airplane. Do they also look at their airplane, look back at the parent, have that shared enjoyment that they're both seeing something kind of new, novel, and exciting? We're also looking at social communication. Do they point to get their needs met? Even if they don't have language, do they have a way to communicate what they're looking for, what they want to express? Are they making gestures? Are they reaching out for others? Are they do they understand nonverbal communication? So how well can they read somebody else's facial expressions? How well can they understand when mom's got that face or dad's got that face that they might not be happy or sad, and put meaning to that? So that the quality of the social communication and social interaction is really cornerstone for the kids who end up having a diagnosis of ASD. We also look at restricted repetitive patterns of behavior. So we're looking to see how kids are able to show flexibility within their routines. Some of our kids have significant preoccupations or areas of interest that they really have a hard time moving away from when they are talking with somebody else. We're looking for more idiosyncratic, repetitive type of behavior. So to see, this might be the more behaviors that you might think of with kids who have ASD, the hand flapping or finger movements, but it can be pretty subtle as well. And then a new category that the diagnostic manual has added in the latest edition, the DSM-5 that we use when we're giving a diagnosis, is looking to see how kids respond to sensory input. We're going to talk about sensory in a little bit, but in my experience, so many of the kids, the vast majority of the kids who have an ASD diagnosis also have significant differences in the way they process sensory information. It hadn't been a symptom in the DSM before until the latest edition, but this is a new thing that they are recognizing. A lot of our kids also have needs in that sensory integration area. So I mentioned briefly that there have been some changes, and the manual that we use to give a diagnosis is called the DSM-5, now the Diagnostic and Statistical Manual. Before, if you have older kids, you may have recognized that we had 5 different diagnoses that we could use when giving a diagnosis on the spectrum. We had autism, we had Asperger's disorder, we had 2 that were regressive in nature, childhood disintegrative disorder and Rett's disorder, and then we had a 5th one called pervasive developmental disorder, not otherwise specified. Meaning that if kids had features of particularly autism or Asperger's, but not enough to qualify for a diagnosis, we could use that kind of more catch-all PDD and OS. In the recent years, there was some research done looking to see how well the inter-rater reliability was amongst clinicians, particularly between the autism, Asperger's disorder, and the PDD and OS. And they found that there wasn't enough inter-rater reliability to keep those distinct diagnoses in our new manual that came out a couple of years ago. So you may see a difference you will see a difference now that it has gone to just autism spectrum disorders instead of having those 5 specific ones. However, all of the literature out there still talks about particularly Asperger's and autism. It differentiates those 2 out. So I know when I'm doing an evaluation, I will use ASD, but continue to talk about what type so families know what type of materials and resources to search. We do have some qualifiers that we use when we're giving diagnoses on the autism spectrum now. We can use with or without intellectual disability. Some kids, about half of the kids on the spectrum also have significant cognitive delays. And we can also then specify it's with or without communication delays as well. So again, just ways to try to help support families in knowing which resources to seek out, and for educators and therapists to know how to best approach a child. This is just indicating, again, those 2 buckets that we talked about, but it's also important to realize that in order to have a diagnosis on the ASD spectrum, that we really have to have seen those symptoms be present very early in childhood, before age 3 approximately. If we have concerns, if a family has no concerns until age 10 or 12, that will likely not be ASD. So looking at that early development is really important when we're doing our evaluations, and as I'm assuming many of you have gone through yourselves, parents or grandparents or caregivers go through a pretty extensive background history interview. So we really need to look to see what were those first few months, early years like, and did we see some quality differences back then and that early? Again, if not, then that might indicate that ASD is not appropriate. Okay. We are able to look at ASD really early in a child's life, and this is very exciting. Again, when I was first starting in this field about 20 years ago, it was not uncommon for us to see kids for the first time at age 7, 8, 9. And not that we can't make differences, we certainly can, but the earlier we get the kids in, the better. And so there's a ton of focus in the research field looking at just how early can we actually see these symptoms and how early can we get in, give a diagnosis. I'm not sure about other states, but here in Minnesota, we certainly have to have a diagnosis before insurance will cover services. So it's important for us to look to see how early can we get in, give a diagnosis, and then start some intervention. At our site, we actually see kids, we have seen kids as young as 6, 7, 8 months of age. Typically, that's the siblings of kids who already have an ASD spectrum, and parents want us to monitor the kids, and I completely understand that, and that's very appropriate. We also, if there are concerns, we will see kids as young as about 9, 10, 11, 12 months of age to start intervention, and I can just anecdotally say those kids just, the trajectory can actually be changed the earlier we get in, and it really help parents learn the skills to embed within their daily routine. So it's not a ton of additional treatment necessarily, but how can we really help support the entire family to help this child get back on track. So looking at the research, it does show that about 3% of the kids, the parents had noticed some differences from birth. A lot of families we talked to said they knew pretty soon after the child was born that there was something that was a little different, mostly because of the way they responded to their name, facial cues, that joint reciprocity, the joint interactions, shared enjoyment. We are able to see some distinct differences as early as 8 to 10 months, and research has shown that we can make a pretty stable diagnosis by 18 months of age. I think I already went over that in pretty good detail, so I'm going to skip that one. So what are the early risk areas? These are, again, the red flags that often bring families in to see us. Looking at the either delayed language or when language did come, it came in a very different way than might be expected. Some kids used words that did not have the same meaning to what other people would use that word for. For example, people might use the word, or kids might use the word door, meaning for a drink, and the word associations aren't always consistent with what typical kids might experience in their development. Response to name, I would say, is one of the main areas of concern that parents bring their kids in to see us. Oftentimes they say, we got hearing checked, everything is fine, but continues to be a concern that they don't respond to the name within the first couple of attempts. Lack of pointing, imitation. Imitation is such a key thing that I think we sometimes forget to look at, but that's how we all have learned. And so if you think about those posters talking about all I needed to learn in kindergarten was actually, a lot of it is true, that we learned by imitating our peers, by figuring out the social world, by looking to see what happened when other kids did certain things with peers or with adults, and then imitate our own behaviors after that. So imitation is a key strategy a key skill that we need to learn throughout our life, not just when they're very young. It's something that often needs to be taught with our kids. Play skills, again, very different interests in play skills as well as areas of interest. The emotional responsiveness, and the more traditional motor movements and restricted interest. The challenging thing when we're looking at giving a diagnosis on the ASD spectrum is that all of those behaviors are typical at some point in development. It's really when we see those behaviors last longer than we might expect in typical development, or they happen more intensely than we might expect, the function is different. So for example, it's very common for young kids to hand flap up until about 2, 3, maybe even late 3s when they get excited. I know I'd go into my daughter's preschool room and they'd all get very excited because a new person's there, and then we see that hand flapping or jumping up and down. Those behaviors are very typical. It's not very typical when we get to age 5, 6, 7. Again, that's lasting longer than we would expect in development. So you have to really have seen somebody who understands, has a good grasp on typical development, to not read into one behavior and look at that as being on the spectrum, but looking at the whole constellation of those symptoms, and then also putting that in context to whether or not that is typical within that age range. So how common is it? It's 1 in 68 kids, and we did get some recent CDC numbers out last year, and it continues to be 1 in 68 kids. So I guess that's good that it's stable. However, one thing that we took note of is that the age of identification has not gone down, despite a ton of efforts across the nation trying to get that early identification happening, and so that we can really, it starts with the pediatricians and other key people in these families' lives to identify there's a need and get kids into services. Unfortunately, as many of you guys know, there are long wait lists. We're going to talk about some strategies with that in a little bit. But I think the focus really needs to be on how can we get this early enough so we can, again, get some support in right away. It used to be about 5 times more common in boys than in girls. I will just mention that it often looks very different in girls. And even though I mentioned that typically years ago we had seen kids for the first time at 7, 8, 9 years of age, I would say that with girls, especially with what we used to call Asperger's, so I don't like this word, but kind of more higher functioning autism, that we often see girls much later in their development than we would see boys. And I think it's just really often times hard to tease apart what that looks like in girls, because it does look very different. Siblings have a higher chance, and we're going to talk a little bit about siblings in a few minutes, and we are seeing it across socioeconomic and different cultures. Although we're talking a lot about challenges for kids on the spectrum, I think it's really important that we look at their unique abilities too. I supervise a lot of staff, and I always tell the staff, your #1 job the first day that you meet a kid is to find out what makes that kid smile. There's something that motivates every single kid, and it's really up to us to figure out what is it that makes that kid smile. What motivates them to learn? Let's use that. So in addition to that, we have to look to see what is every child's strengths, and everybody, all these kids have amazing strengths. You'll hear me repeat some themes throughout this workshop, and that's, I think, repetition helps us all learn. But one of those themes is that every single child on the spectrum is very unique and very different. There are some commonalities across them that help us know how to best teach kids on the spectrum. But with that, these kids have amazing strengths, and I know it's up to us as clinicians and providers and families to identify what those are. So here's just some of them. These are not an exhaustive list by any means. If you've been watching the news recently, there has been more and more companies even that are only employing people on the spectrum because of such abilities and strengths, that they are the ones who show up on time every single day. They have amazing memory skills. They have a way to see the world in a way that many of us don't, and can provide such insight into us. So I know for me personally, I don't do a lot of clinical work at this point, but I keep a caseload of my adults, because they can articulate and express the ways in which they view the world in a way that really helps me understand and better myself, as well as when I do evaluations and work with younger kids and help families understand as well. So I'm going to talk about a visual and how we have described ASD here. It's just a way to try to help concretize such an abstract concept. So if you look at the bottom axis, I'm going to talk about just some general developmental areas. I'm going to talk about gross motor skills, fine motor skills, expressive language. It's how we use our language, the words that we use, the language we produce. Receptive language is how we understand language, follow directions. Cognitive skills, social skills, and self-help skills. You can really take anything, but just that's an example. Along the y-axis, we're going to talk about ages. So if I had a child come into the clinic and I did some assessments, let's say that child is 4 years of age, I would find that their skills across their development is relatively age appropriate at that 4-year range, for example. There is some waiver to that line because we all have our own individual strengths and areas of needs, but for the most part, it's consistent at that 4-year range. I'm going to try to differentiate now for you delay versus disorder. So if we had a child come into the clinic who was showing primary developmental delay, so somebody who maybe has Down syndrome, for example, or someone who has cognitive disabilities, we would see that maybe they're 4 years of age, but all of their skills might be functioning more like a 2-year-old. So again, they're consistent. There's some waiver, but relatively consistent at that 2-year mark. Compare that now to a child or disorder, a child who might have disorder, and you often find that they have skills all over the map. This again goes back to that notion of the need to really find the strengths in every child, because their profiles might look different from one another. And this oftentimes can be challenging when working with kids on the spectrum because, for example, I've worked with many kids whose expressive language might be age appropriate or even above what we might expect for their age range. But their receptive language might be quite a bit below what we would expect. So it's hard to understand when you're working with somebody who has full sentences, can communicate as you would expect, but not following directions. Not because they can't, but because they don't have the receptive language skills to understand that. These are the type of kids who often come to us from schools who may have said they're naughty, or not understanding it's not a behavioral component, that they just don't have those skills, or those skills are lower, I should say, than in the other areas. So this is why it's important to have a good IQ test done if you have not had a good cognitive test done, just so we know where those skills lie. And hopefully in intervention, we can make that line a bit more consistent. All right, just to show a little bit of the continuum or the spectrum that we're talking about. This is not exhaustive by any means, but again, if you look to the left, you'll see the different skill areas or the different categories we're talking about. So communication, social interaction, repetitive behavior, sensory learning style, and IQ. Look to the left to see that the spectrum that can be held within each of those areas. So in the area of communication, we can have a child who is completely nonverbal to a child who has superior verbal skills. Social interaction, again, we've got kids who may have very limited social interaction and might be okay with that. Some kids are fine not having a lot of friends, but some kids who really are desperately seeking that, but yet continue to have struggles knowing how to maintain those interactions. Some kids have very mild repetitive interest. Some kids have significant, to the point that it really impedes their ability to function within kind of their society. Some kids are hyposensitive to sensory and hypersensitive. So you'll see, again, the wide range, which again is an illustration that each kid on the spectrum is so different, so unique. We really have to look at that particular child in front of us to say, what are their strengths, what are their areas of needs, and develop an intervention around that. I'm also going to spend just a couple seconds on the sensory piece. I am not an OT, so if you have not seen an occupational therapist, please do so. I think this is one of the most important pieces that you can do for your child. In all of my years, I have seen the majority of our kids have significant sensory processing differences. And what that means is that if we all stop to just take a moment and think about our environment around us, our space around us, think about the sights that we're seeing, what we're hearing, the smells, most of us can filter that out. I'm in a big city right now and there's quite a bit of traffic going by me, but I can filter that out and focus on what I need to. I happen to have fluorescent lights in my office. Again, I can filter that out and focus what I need to. Kids on the spectrum oftentimes really have a hard time taking all that in and filtering it. So I've had lots of kids will say to me, I see the blinking of the flickering of the fluorescent lights. They might get stuck on a certain sound, on a certain smell, and have a really hard time focusing. So in my experience, I find that if our bodies are not ready to learn which if they're flooded with all the sensory information, it's really hard for our bodies to be ready to learn the other strategies that's trying to happen can be pretty challenging for our kids. So not all kids have sensory needs, but if you have not had a good comprehensive occupational therapy assessment, that would be one of the first steps that I personally would recommend families to do. Okay, we're going to talk about some of the underlying challenges that our kids also are faced with. Looking at executive functioning skills, the planning, the organizing, shifting, how do you self-check, all those things that we all need to do every single day to make it through our day. And again, thank goodness for smartphones for most of us. We rely heavily on that. It's a very similar approach to our kids, how to help them access the tools they need to be independent in their executive functioning. Again, when they're real little, we do a lot of that for them. We also use a lot of visuals for a lot of our kids when they're real little. This is my plug that I think we are pretty quick to take visuals away from kids when they get older, when they start to show more skills. But a lot of our kids continue to need some visuals, some reminders. Again, we all rely on I rely on my smartphone, I should say, very heavily on my calendar, my to-do list. Same things with our individuals. The visuals might be for young kids, it can be a schedule in pictures, it can be a choice board, what their options might be for for older kids. Again, to-do list, scripts, nothing fancy, but think about how you can help these kids who tend to be pretty visual learners. Not all of the kids on the spectrum are visual learners, but many of them are. How can we help them learn the information and see it in a very visual way? Okay, so we're going to jump into how do you actually structure the intervention for your child. So I'm not seeing any questions yet, so I'm thinking that we're good. But if you have any, please feel free to chat with me in the box. So this slide is really showing that it's about developing a team around that child and the family. And that team, the team members might have different perspectives, but it's really important that we come together, collaborate, have the family and the child in the center. Really, I feel strongly that the parent should drive it, but one of us should be in the seat next to them. And sometimes we take over for a little bit, and sometimes we give the wheel back. It's a fine balance. I'm going to say this over and over again too for parents, especially if you're parents of young kids. There's so much research showing that if we give parents the tools to embed these strategies within their daily routine and/or get parents at the helm, you guys are the biggest change agents for your kids, and the change happens most quickly when we have parents who are right in the middle. However, it's a fine balance too, I think. We don't want parents to feel like they have to be therapists. Parents have to be mom and dad and grandparents first. That's the most important part that you can ever play with your child. So you'll hear me say that a few times, but I want to make sure that you hear that there's a balance to be had here. But at times it really is important to have the parents in the middle. So what we're looking for is how can we help the parents and families or grandparents develop that team around them. Here are some of the key players that we would recommend to be on that team. If you're looking at specific behaviors, you would have a mental health clinician. So a therapist, I think, to really help see the broader needs of that child and or the family as well. So thinking about what are the parents, how the parents getting their needs met, how the siblings getting their needs met. Might be behaviors of siblings that we're looking at, but again, a mental health professional at some point to help and tie it together. Pediatrician, of course, is very important. We're going to talk about their role in a little bit. Occupational therapy we mentioned as well. Again, a lot of behaviors can stem from sensory dysregulation. And so looking at that comprehensive assessment. Early childhood is key. I'm going to talk about school in a minute, but to have that professional school team is absolutely essential. Speech therapist looking at the communication, and then of course pediatrician looking at the medical piece as well. So we're going to talk a little bit about how do you translate your needs into intervention. Where do you start? Really, there needs to be what we'd refer to as a golden thread. And so there you have referral concerns. There should be a good comprehensive assessment, and then treatment planning with that, hopefully with the individual that did your comprehensive assessment or with the school staff We're going to mention this in a few more slides, but school goes through a different assessment than you might go through for a medical diagnosis, at least in the state of Minnesota. They're not one. You have to go through medical diagnosis by a mental health professional and also the school team to see the eligibility for school services. So you start with that good comprehensive assessment, both the medical side, school side, the treatment planning, so looking at what services and supports that child need in school, as well as an outpatient and or more intensive therapy services. Intervention should happen, and then you should hopefully see outcomes. And then you might start that thread again as referral concerns change. As your child gets older, those concerns might become different. So again, go through that assessment process. Again, make sure that you're always starting intervention or change of intervention, look back up with a good comprehensive assessment. I mentioned just this briefly again. There are those two different paths to services. Actually, there's 3 in the state of Minnesota. I'm guessing in other states as well. Educational system, the medical system, and then the community system. So the communities, the counties here in Minnesota are the ones that can provide additional funding for families. This can be a very expensive journey. So families oftentimes look to see what additional backup insurance counties might be able to provide. Respite is incredibly helpful and useful to many families. So having a county social worker is, again, very important to have on that team. If you don't already have one, contact your county to see what they might be able to support. There was a project done in 2009 that looked to see what are those components of best practice interventions. And we'll go through a few of them here. This is not, I can't go through all of it in an hour, but looking just to see what are those components that you should be looking for if you're deciding on intervention for your child. So again, there should be some decision making that includes you in that process. There's that professional judgment, value, and fidelity, I think, is really important as you're looking to see what option might fit your child and your family. There should be some system in place to check the fidelity of the staff who are working in that facility. So I know we have fidelity checklists that we call them for every level of staff, and that we are continually going back in to make sure that that staff is working to the fidelity that we expect and how they were taught. If you don't do check-ins, things could get lax. So again, I would just ask that if you're going into interviewing places, looking at options, how are they assessing staff and making sure that staff stay at fidelity to the model that they are trained in. A couple of other things, again, how early are they able to start kids intervention? How well do they individualize the service? There should be an initial meeting, and we've talked about this, a repeated theme throughout this morning, but how well is that model or program looking at that child in front of them as an individual? So how are they looking to see how we can fit our intervention to them versus the child fitting into our intervention process? Looking strengths, areas of need, and also the family. So I think it's really important to consider the resiliency and where the family is in that process as well. I have seen some kids who I think might really need an intensive 5-day, weekday treatment program, but the family is not there for whatever reason, completely understandable. So our services might actually start with the family support to get them ready to come in 5 days a week, for example. So looking at, again, what does that whole family need, not just what the child needs, although that needs to be front and center as well. Should be a systematic planful teaching. You should expect very specific treatment goals that you are part of. It's really important to have that family engagement in talking about what are those treatment goals, how are we going to monitor those goals, how are we going to know when we're done and moving on to something different. And there should be some sort of a curriculum or a path that you can see how you can get from step A to step B. And these are all questions you can ask when you're talking to potential providers. Here's just a list of some of the evidence-based interventions. I will say that at least in Minnesota, our state and our insurance providers are starting to only provide or to reimburse for those evidence-based practices, which I think is fantastic. There are some out there that are not evidence-based, and those are the ones that are going to be more private pay, and not that they can't be beneficial, but they just don't have the research behind them. So anytime a parent asks me about something that is not evidence-based, I think it's really important that you just carefully research, talk to families who may have gone through it, talk to anybody you can who knows about a non-evidence-based, but these in particular are pretty strong models. So if anybody has questions about any one of these in particular, later we can talk about that at the end. I think you might see that oftentimes programs will grab from pieces from each of these. I think that's okay. Oftentimes you'll see that one isn't a replication site of just one particular methodology, but still they're pulling from those evidence-based interventions. Just showing a little bit on the spectrum of interventions. We have some that are very much more on the behavioral side and some are more focused on the social behavior. However, I will have to say, I think it's a really good trend that this spectrum is condensing more over time. When I first started, there was a pretty significant difference between the more behavioral approach, which we tend to think of as can be more of the ABA, applied behavioral analysis, and then some more of the social behaviors, such as the Stanley Greenspan floor time and the RDI model that you might see on the screen here. But really, over time, most programs are, again, collaborating, coordinating the range of services, which I think has been extremely helpful for our families and kids and much more effective. Okay, from the wise advice of parents who have gone through this, again, they often say, if I had to start over again, I really want to start having everything organized. I know that's incredibly hard to do, but important as you're looking at going through these assessments, you'll get a ton of paperwork. So if you're new into this journey, I will just say, again, from parents, they recommend it to try to pull it together. A lot of times, if you go to school, for example, have the assessment done first, and then come and see me as a mental health professional, I might not have to redo a lot of what the school had done if I have that report in front of me. So collaboration, coordination amongst providers is key. Until we get an incredible system that lets us all talk to each other, some of that does rely on parents to provide that information back and forth. So just a tip. So as I mentioned, there are wait lists, and that's unfortunately how I think most states are that I have heard so far. A couple things to think about is get as many wait lists as you can. Ask about cancellation list. I know we ask families if they are able to come in last minute. Sometimes people do cancel and we can get somebody in quickly. I think the third bullet point is really important to proceed with one or two, probably not more than 3 interventions at one time though. When I am going through the recommendations after an evaluation, I always feel so bad for parents because I just see their eyes start to gloss over as I start to go through the 12, 13, 14 recommendations I might have. But we spend some time talking about what's priority 1, what's priority 2, what's priority 3, and so forth. If you start them all at one time, you're going to stress yourself out and you're going to stress your child out. And we're not going to know what's working, what's not working. So looking to just know it's okay to not start everything at one time, and how do we again figure out what's most important. It differs for every child, so I can't tell you what's number 1, number 2, number 3. That'd be something that you'd have to talk to the professional who did your assessment or the school staff, but know that that's not usually effective to do as many, plus it's going to stress the family out. Monitor progress 1 to 3 months. Give it enough time to know if it's really making a difference. Something I like to do with the families that I work with is to ask them up front, how are you going to know that it's working? How are you going to know that you're making progress? Because what I might see is being progress might be different what the family is defining as that. And to have that mutual language up front, I think is incredibly helpful. So if you can just spend some time with a therapist or the school staff who's going to be doing the intervention, and make sure you have that laid out so that you understand what the school staff is looking for, but they understand, or the school or professional staff is looking for, but you also know, they also know what you're looking for as well. Okay, so just looking again at some of the research into the early interventions, it should be started as soon as a diagnosis is suspected. Knowing that there are wait lists to get that full evaluation. If you have not had that, sometimes you are able to go into providers and and get at least a provisional diagnosis or a rule-out diagnosis to get some support started. And then looking at some of the long-term outcomes, again, you can see those improved IQ scores, improved functional communication, adaptive skills, and social skills. And of course, the goal they're all working for is to help these kids and adolescents and adults be as independent as possible. I think I talked about this. Again, your goal should be individualized. Make sure that you're having some input into your child's goal, and that at the time of review, at least for here in Minnesota, we have to review goals every 90 days and make sure they're still appropriate. I'm hoping that families are brought in and should be brought in at that point to make sure across all the states. That's a really important piece to make sure that, again, we're all on the same page. We know what those areas of needs are. We have that common language as to, yes, this is effective. No, it's not. We have to tweak it here, tweak it there. The needs change, and that's okay. Sometimes we've started kids in center, and the needs have changed, and now we need to move it in-home for a couple of times, or we need to actually move it to more of a family structure versus just individual work. We need to bring in a sibling for this time. We need to make it more intense for a little bit. We're going through a rocky period. So those needs change, and that's at that 90-day or whenever your reviews are within your state. It's really important that you have that input and are collaborating with the professional. Having said all that, I just want to recognize that it can be challenging given some of the finance, the waiting lists, the schedules, and availability of services. So again, talk to your county social workers. Sometimes they're able to provide some help with the finances. We talked about the wait list. Schedules, that's a challenging one. I know many families have multiple kids. So again, if you can work with your clinician to find out what are you able to do at home. There's also some really good books if you have a lack of services close to you. Sometimes programs are able to do WebEx or telehealth. So it depends on the state and where you are, but some options. Okay. Also, we're going to talk about now what to do at home, at school, and the pediatrician's office. And I think it's important to talk about also the family's need. I've mentioned this before, but I can't say it enough that I see so many families and parents who will jump in and do and give everything they can for their child, and I so applaud families for that. But it's also important that they look to see what their needs are individually and as a couple or family system, whatever that looks like for your family. And it's okay and important to go through those steps of grief that many families do experience. To know too that what I often hear from families is that grief cycle may come back at certain times in development when there are milestones that you thought you might have it look different at this point. So it's important to see how you individually can, and as a couple or whatever your system looks like, can make sure that you have your needs met. And that might be more formal supports and might be natural supports. I'm going to talk a lot about natural supports and formal supports. Formal supports are more of the center-based and psychotherapy, family therapy. Natural supports are those the extended family around you, the neighbors, the support groups you might go to. Those are all incredibly important too. And I'm so thankful to hear that our society, at least here in Minnesota, and what I'm hearing around when I do travel a little bit, that there's more of a focus on the natural supports and having us identify those for families so that they're not so reliant on the formal supports, because we come and go, but the natural supports are hopefully there for a lot longer. So how can we help families, again, create that team, which includes those natural supports, very importantly. Understanding everyone copes differently, and how can you ask for help? And I've heard from many families you have to somehow find humor just to make it through someday. And it's okay to find humor and to find those moments of fun, which are very important. I'm talking to supervisees, I often ask that. What do they do for fun? What can we have? Can we build in, help them build in even 2 minutes of fun a day? Whatever that might look like for a family might be different. So how do you get started? Read, research. There's community resources. Here in Minnesota, we have the Autism Society of Minnesota. I'm assuming there are many other chapters around in different states as well. They can be incredibly helpful in getting resources and getting connected with the community. And now ours has a lending library, so you could look to see books that might be available and actually just rent it from them for free, actually, without having to spend a lot of money into books. So that would be something to check out in your state. There is an Autism Society of America that's excellent. So one place to get connected. And then consider FMLA. Sometimes parents are talking about the stress of trying to make it to all of the different appointments that kids oftentimes have, and trying to keep a job, and something just to think about. I know that that does work in Minnesota, at least for if kids qualify, which they oftentimes do if they have a diagnosis of ASD, you can get intermittent FMLA, which just gives parents oftentimes a little bit of peace of mind. Okay, we're going to talk about embedding again the intervention. How can we help support the families in their home environment, making sure that we can support the sensory needs, the communication needs, and expand on positive activities. So once the kids have learned something, how can we then move it to a different setting, adding a different person to make sure it's really well established? And I think the last is important, that fun motivates ongoing learning. Therapy is really important, and we have a day treatment program here that's 5 days a week, which is very intensive, and learning is very serious, but we also tell staff you can't lose the fun. These are kids. They learn through play. We have to make it fun. We have to be having fun ourselves to help the kids be motivated to want to keep on learning. Siblings, I'm not going to talk a lot about siblings other than it's important to watch their development as well. Sometimes we see that kids who have siblings on the spectrum might have other learning needs or anxiety or depression sometimes. So just to make sure that we're watching what their needs are as well. By providing information at their developmental level. Again, there's so many great books out there now that were not there even 10 years ago, talking about how to describe what ASD might be to the siblings for different age ranges, support uniqueness. And again, the research is showing that while it's not easy, a lot of the kids do fare well. I know a lot of my coworkers here have siblings on the spectrum, and they just come with a different perspective than most of us can share. I think it's important to also recognize grandparents are really important players on the team, and how to support them. Again, there's many good books out there, but to just kind of start to think about the whole family system, and that oftentimes grandparents describe almost this double loss, and that they want to help their child, but their child is struggling with their child, and so we again need to support them all. And oftentimes it's helping them to understand the ASD. This is it's not new, it's been around for a while, but the intention has not been there until probably the past 10, 15 years or so. So a lot of it's education, which there's so many more options with that for that now as well. Pediatricians, of course, are very important to look at the health, improve the understanding. They can offer information. School, I'm going to just jump a little bit from this just for the sake of time. This one got out of order a little bit, so I'm just going to go to school. I will say that schools are doing an incredible job, and I will talk about Minnesota at least. They're doing a very good job serving our kids. Also know that it's really important for families to be part of that IEP meeting, which can be quite intensive at times. And so know it's okay to bring somebody with you. A lot of parents say, I didn't know I could bring my friend with me who has been through this before. Again, a natural support with you to help. Sometimes if you haven't been to those, it might be 8, 9, 10 people, school staff there, and then you and your partner, and that can be a little intimidating. So bring who you need to, even to take notes. For someone just to take notes can be incredibly helpful. If you need help advocating for your child in the school system, I know Minnesota has, we have ARC, ARC, which I do think has chapters in other states as well, or advocacy groups who can really help you read through the IEP, make sure that what your child needs is on that IEP, and that they're actually providing what they say on that on the IEP. Here in Minnesota, they will send people to IEP meetings with parents, again, just to be a different voice and to help make sure that kids are getting what they need. Okay, I'm just gonna jump back. Oh, I'm sorry, I'm gonna jump back one more time. If you have not had a school assessment for ASD, but your child has a medical diagnosis of autism, ask for that. You might have to ask for that specifically, but that is what will give them specific ASD interventions at school. Okay, with the pediatrician, some things just to think about. You might want to look at neurological screening. Again, sleep problems are very common in our kids. Diet, that would be the place to go for support with that. And I'm cognizant of time, and we have just a few minutes left, so I think I talked a lot about the community resources. I put a bunch of asterisks next to the internet because no, there are a lot of very unhelpful things on the internet. And again, ask providers to point you in the right direction. Really well-established ones, again, are like Autism Speaks, Autism Society of Minnesota. There's a couple of other, and your state might have specific websites as well. This is really just showing those natural supports that I talked about a little bit, and that I think it's important to note that natural supports for kids and families on the spectrum might not come as seamless in development as maybe in typical kids. So we oftentimes have to work a little bit harder for our families and our kids to help them to create those natural support networks around them, and if not, we're going to see this isolation. And they certainly can develop, we just have to support that more directly. So in summary, again, we want to try to delight in the strengths. These kids are incredible kids and they can teach us so much while we also are addressing and integrating their challenges. So there's a fine balance. Hopefully each of you can find somebody to help you navigate this. It might be, again, a formal support, it could be someone who's been through this before. Other parents can be incredibly helpful. I know they can give far more than I can because they've been through this. So you can even ask if your state has a parent network. Minnesota has a parent network where families can reach out to each other and you get paired up with a mentor who can help answer your questions. So with that, I left just 2 minutes, and I know you already have these slides, so you can look through some of the different resources that we have listed. If here on Autism Speaks, if you haven't looked through their website, they have excellent kits, toolkits to be used. If you're brand new to this, download their 100-day kit. It's excellent. They have it for school-age kids as well as younger kids. Helps you organize all of these things we talked about and helps you develop that team, again, that we've been mentioning today. So with 2 minutes left, sorry about that, I know we got a late start, but does anybody have any questions? I think I see somebody typing, so we're going to just hang out for a minute.